I will talk about a large IT program within one of the healthcare region in Norway, the so-called Southeast Regional Health Authority, which is the one Oslo is a part of, and it's the largest one, covering 56% of the Norwegian population, according to Margun's figures. And they started a program which they called Digital Renewal in 2012. And then in addition to covering more than half of the Norwegian population, in this organization there are between 75 and 80,000 employees. They are organized into 11 hospital trusts, we said there, or maybe hospital enterprises. Before the government was taking over the ownership of all hospitals in Norway in 2003. Before that, the hospitals were owned by the counties, and there are 19 counties in Norway. And so before 2003, I think it's 9 of the counties are part of this this health region, and before 2003, these counties were having what they defined as somewhere between 40 and 50 hospitals. So that structure is certainly very much present. And when they started, our best guess was that they had about 4,000 different software applications within the region. Now, when the GDPR is implemented, they need to have better control over the applications, so now they have counted. And I think it was in May they said that they have finished the counting, and they have identified 5,730 different applications. And each of these applications are integrated with a number of others. But the overall experience in 2012, as previously, was that this was a very messy structure, very expensive. It was fragmented, the lack of integration, so that information sharing was all too difficult, and so on. So what this program was about was, in a way, to clean up the mess. And during that program, things have happened outside this. New technologies are coming along, also having an impact. Internet of Things, mobile apps, and so on, as just 2 examples. A bit more on history of IT in this region. They started in the 70s introducing systems. I think in the beginning it was a focus on patient administrative systems and then on lab systems, and then more and more. So over the years they have introduced more and more applications. Applications have been developed to support new work tasks, new areas. During the 80s, communication technology came along, and then the possibilities for integration and sharing emerged, and then that became an important issue. So they started, and then they have a number of systems, and integration was an important issue around 1990, or a little bit before. They started to work on the development of standards. Personally, I got involved in IT in healthcare in 1988, and I was engaged on a project where the aim was to contribute to the development of international standards for information sharing in healthcare. And in a way, that changed my life. So then the focus during the 90s was to standardize messages so that you can exchange information as messages between applications. In 2003, when the government was taking over the ownership of the hospitals, and they set up a regional governance structure, these regional enterprises, and in all regions established an IT unit, and they developed a regional IT strategy, and all the region concluded that the situation was very messy. This message standardization effort had not delivered, so it was the situation was still very messy and chaotic, and they needed to do something differently to clean up the mess. And the strategy all region arrived at was that we need to do something more than just standardize messages for information sharing. We need to standardize the applications. And that meant that each region should have a regionally standard patient record system, a lab system, and all important applications. All hospitals within the region should use the same product from the same vendor. Then information sharing would be easy. In 2012, the situation was, and that is what is going through the whole history, there's a permanent, that the level of chaos and mess has stayed constant. And that is not just because this strategy has not contributed, it has contributed, but every day they implement another standard or standardize, there are more systems coming along, more new applications supporting new areas, and new products. A vendor is coming with a new version which is different, and so on. So in 2012, when they started this program, the level of chaos was as big as ever. So then they concluded that this strategy had not worked either. And actually they said that the hospital, and that means these 11 hospital enterprises, had they decided on how to implement a new patient record system and how to do that. And so then they said that they were configured differently. So these different installations of the same product were as different as if they had been different products from different vendors. So they needed to do something differently, and what the silver bullet they believed in and decided they would believe in at this point was what they called consolidation of applications, and they should replace all existing patient record databases with one single database and one software module used by all users. Then the mess would disappear. So then they started this program with a focus on the main areas, most important patient record system. At that time, all hospitals except Oslo University Hospital was using the same product. So then the first step in this area was to implement this product, the system at Oslo University Hospital, and then consolidate all these installations, databases into one. Lab system, they decided that they should have, and here lab, in that project there was a focus on what they said was 4 main labs. It was a medical biochemistry, it's called. I think it's pathology, blood bank, and microbiology. They will have one product for all hospitals, supporting those 4 labs. And they were running a tendering process and decided in 2014 on a specific product. In radiology, they did the same. Radiology information system and a PAC system. Collaboration was another area, and collaboration here means information sharing with healthcare units outside the region. Most important, implementing this national solution, the e-prescription, the summary care record system that Margen talked about. And then there was one project on management support and one on infrastructure, because the basic infrastructure was very heterogeneous. So to make this work, they needed a coherent infrastructure, and they decided that they should outsource the operations of the infrastructure to someone that could deliver that service. So here there was a tendering process as well. And the budget was about 2 billion Norwegian kroner every year. That means almost 200 million pounds every year they spent on this program. After 6 years, the outcomes in the patient record area, they implemented that product, and the requirements was that this new product should support just what should be a plain vanilla kind of implementation, not one single additional feature to what they already had. It was just a minimal implementation replacing the existing system. And it was, they went live on, according to the plan, in October 2014. They spent about 60 million euros just on this minimal implementation at the hospital. And the minimal implementation included a minimal number of integrations to other systems. An absolute minimum that they had to integrate with was 60 different other applications. And when it was up and running, users requested integration with 60 additional applications. I don't know how many more they integrated with. And then they started to estimate and plan the consolidation of the different 11 different installations. And they concluded after 2 years or something that the costs would be somewhere between 130 and 200 million euros, between 100 and 160 million pounds. And then they concluded, or the hospital doctors that had to pay for this, they started to ask if they would get value for money, if this consolidation was worth this big price. So I'm not sure about what kind of decisions they made on this, but it was, they have not followed the plans to do this. And integration with other systems was the most demanding task, and I think the estimate was somewhere between 30 and 45 million pounds for doing the required modification of the integration with other systems. And then in addition to that, they also were planning how to convert the existing installations to the new version of the product, which Margin mentioned, which is under development, and they estimated that to around 90 million euros. On the other project, partly they did some reorganization because when they started, this was defined as a program, and these were the 6 projects under the program. But then, after some time, they discovered that there were lots of dependencies between the patient record system, the lab system, the radiology system, and so on. So to deal with that, they reorganized and put all of those 3 into one project, which was called Regional Clinical Solution. And then I also started some other project which was included there, charter medication system, a new system supporting chemotherapy treatment, and some others. But without making any decision, it was obvious to more or less everybody that this patient record consolidation strategy it was not a good idea. So they gave up that, and what they did without making any big decision was that they started to standardize piece by piece the databases and started to implement searches across all these databases. And now the first one was to support a system for giving patients access to information, and that was developed an API so that product could get all the documents that were stored in any patient record system, and so that a patient could get an overview of all the documents in his or her medical record across the region. And then they have developed some more. So that is, it's a kind of limited stepwise strategy towards some kind of regional shared solution The lab system, I think it was estimated to cost 100 million Norwegian kroner, about 9 million pounds. And after 5 years or something, they have not achieved very much. So they decided to take one of these different applications and the first focus on pathology, and they will have a pathology module that can work for all hospitals. And I think now the budget is that it will take 10 more years and cost 10 times as much as, or now the estimate is that it will cost about 100,000 million pounds. In radiology, they signed a contract with former Kodak Carestream, which is a big supplier, supplying radiology systems worldwide. They have cancelled the contract after they started to work with one of these hospitals, and after 4 years after the contract was signed, they gave up. They were not able to deliver a system that the users were willing to accept. Lots of errors. I think the first acceptance test they started in 2014, October 2014, and it stopped it immediately, more or less because they discovered it was so many errors. And they tried to fix the errors and worked 4 more years on that. And now also the users are saying that they do not want to be involved in that project. They have absolutely no trust the vendor that Carestream can deliver, so it is sort of impossible to continue. So they have cancelled the contract, and they have decided that each of these 11 enterprises should have a consolidated system, because inside each of those enterprises there are 5, 6, 7 old hospitals having different systems. So they would have one shared system for each of the 11, and then and here they made the decision about a new strategy, and then implement APIs for queries across these installations so that they can have a kind of virtual consolidated system. The infrastructure project was stopped and cancelled, and that was after it came to the media that software developers in Bulgaria had access to patient records, because the company, not DHL, but what was the name of the company? Big American, the former HP. Yeah, yeah. They got this contract, and they had people employed in various countries, software developers, and it came to the media that those doing programming here had access to the patient record. And then the managers said, no, we have perfect control, no unauthorized access to patient information. But then there were people working within the region that knew that they had. So there was more leakage to the media. And then the managers were, first they told the media and they told the top manager of the region, and then they were called to a meeting by the Minister of Health, and they said, no, we have perfect control. But then it was clear that it did not. So then they stopped the project, and the top managers were fired, also partly because the lack of success overall in the program. But what made them push the button was this infrastructure contract, and then they worked for 1 year finding out what to do, and then decided to cancel the contract, and that they would take the responsibility for the operations of the infrastructure themselves. But there were also some successes, and they built a new hospital in one of the counties, and first it was a plan that they should use this regional solution. But then it pretty soon became clear that they would not deliver on time, and here it was decided when the hospital should open, so then they had to have working IT solutions. So then that project in delivering those solutions were taken out of this program, and they were quite successful implementing the basics, but also some more innovative solutions. And one we have been following and look at is a solution delivered by a Norwegian company called Informatics. And what they deliver is basically supporting patient logistics coordination between units and any kind of personnel, also those cleaning the room and those delivering the food and so on. And we call this a lightweight solution. It's implemented as a number of apps, accessing the patient record system, the lab system, radiology system, medication system, and some others. And they have access to this on whiteboard in the emergency room and in various room where the nurses have a meeting discussing the distribution of work related to patients, and also mobiles. So this has been an interesting, quite successful solution. And about a year ago, this hospital was evaluated by this international organization ranking hospitals from 0 to 7. And this was ranked 6 as the first in Scandinavia. And in parallel with this, I have, over a long time, implemented a quite powerful, what they call integration platform. And integration, in a way, has been a major issue, at least since the 80s. And I started more doing ad hoc integration of various kinds, and then around the late 80s, I started to discuss standards. As I said, I got involved in a project in 88, trying to do that. And here the idea was that when they agree upon the standards, the vendors will implement the standard, and then it's just plug and play. And many seems to believe that still, I think. But it was clear that it wasn't that easy. So also during the 80s, various middleware products started to emerge. One was BizTalk, Microsoft's Enterprise Service Bus, and some hospitals started to use that in the 90s. When they established the regional IT unit, they were taking over the whole responsibility for IT and operations, and they were taking over responsibility for this, the BizTalk installations, and they were responsible for the operation, but also doing the integration work. And they were adding, and also in the early 90s, I know that many hospitals had a different middleware products supporting information exchange based on DICOM, the DICOM standard. They had at least 3 different products within the region. So the regional IT unit was also taking over responsibility for that, and they established a unit which I called first the Integration Factory, which is later renamed as Integration Services. And they're, as I said, responsible for the operation of the integration software and the integrations and doing all the programming for integrating system. And over the years, they have implemented a more and more powerful and extensive integration platform, which also includes Microsoft's Internet Integration Server, which is middleware supporting web services, so-called API Gateway, which is helping you to have offer secure access, and identification, authorization, management module into this. So this is a quite powerful thing, and this has been developed very much under the radar of the managers, but have actually contributed to the level of integration and information sharing which they actually have, which is quite extensive in many ways. So the lessons learned from this product, we say that here that it's a failure of what we call application theory. And what I mean by that is that people involved here, like most, both users and IT people, think about IT as being about applications. Patient record system, lab system, PACS systems, charter medication system, accounting system, whatever. That is what we have. And we have a larger and larger number. But it's, and there is, and this is how we've been thinking about IT as we started developing software for users in the, let's say, 60s. And in our opinion, an organization like this, and most other organizations as well, desperately need another concept helping them understand and deal with the totality of IT solutions they have. And what in this program, they have 5,000 applications, and then they are integrated with each other. And also, if you read software engineering or information systems development textbook, it's also maybe not explicitly, but at least between every line, they tell you that software development is about developing individual application. And the way you do that is that you go to the user, ask them what they want, and then you establish a project and develop it and implement and deliver it. And then you have a little bit of user training, and all is fine if you do things according to the textbook. And what this tell you is that software, IT, is about individual application, standalone, developed from scratch. And that is as far from reality as you might get. Because of these 5,700 applications, each of them are integrated with tens, maybe hundreds of other applications. And how do you deal with this totality? Then some says that we should have a suite implementation, we should have Epic. And that is another application. And then we should replace all applications with just one application. And, but Epic doesn't cover that much. You could replace 2-3 of the applications here, and you will have 500. And if you had 5,736, you would have 5,730 left anyway that you had to deal with. So, and we, as an alternative, we are talking about this and conceptualizing, theorizing this totality as infrastructure. And specifically, in this case, we see what they have succeeded with as, or say that one way of seeing that is a beginning of the first step of a transformation of the whole portfolio towards what could be a platform-oriented infrastructure. And that they move towards that step by step by developing APIs and so on. And some of the activities with the APIs searching across the patient record database and standardizing the databases, what they are doing in radiology, is a step towards that. And also this solution supporting patient logistic can be seen as a number of apps running on top of some platforms. And to explain, now I'm also running out of time, but spend some minutes on trying to explain the concept. I assume that all of you are talking a lot about platforms. All of us are now calling everything a platform, and a bit too much. But we have an iPhone, the Android platform, Facebook, Google, Airbnb, Uber, and all these platforms. And in the literature, with the research literature within our field, there are basically two definitions of platform. One is as a marketplace, Uber and Airbnb, and the other definition is saying that a platform is an extensible code base, and that's Android and an iPhone is a platform you can extend the software with new apps on top. And Android and Uber is a combination. Android and iPhone is a combination of these two definitions. Android is extensible code base, but also it's a marketplace where users can buy apps. A marketplace where app developers and app users meet. Some with a focus on this extensible code base definition. Some are defining a platform like this 3-level model. You have a platform core, which is the platform, and then you have boundary resources, which are the APIs that are available for app developers to get access to the platforms, and then you have the apps. And then they're saying that there are 2 functions related to this, which are basically taken care of by the platform owner, and that is resourcing. It's some of the resources here they are making available to app developers, and then they are also taking some measures to secure the integrity of the platform and so on. So you have securing. So that is simple definition of a platform. And then within this program, or related to the program, a lot of people started to talk about that we need to support more innovations. And actually top-level managers accepted that and initiated some projects and so on. And innovation means that you need access to the core system, the patient record system and so on, any new system for healthcare, almost. We need that. So then emerged the idea of seeing this basic application as something similar to the platform, that apps and app developers should get access to the database, to the information there, in the same way as we on these things we call platforms, where you get access to the platform. So then we see an application like a patient record system as what is often called a platform ecosystem. You have the database, the platform core, and then you have the user client, could be seen as a number of apps, similar to apps, and then you have boundary resources. And all a patient record system have lots of boundary resources, which can be used for integration with other systems. So this is one way of looking at an application. And when you're talking about platforms and in the research literature on platform, the focus is only on one individual platform, also seen as isolated, except that apps are connected to it. But it's Android, Uber, always are Facebook, seen as one isolated thing. But in reality, they are integrated with other platforms. The mobile payment system is integrated into the global bank payment exchange infrastructure and so on. So there will be a multiplicity. And if we look at the main systems or applications within a hospital as a platform, there will be a multiplicity of platforms. So one issue is on how to deal with this multiplicity of platforms. And then we came to see this powerful integration platform as a boundary resource, because all access or information systems between systems in the region takes place through this integration platform. So then we see that as a boundary resource on top of the individual platforms, where each platform, each product is a core. The platform has its platform core, roughly the database, and then some boundary resources to access that. And then this integration platform on top of this, and then all apps are accessing the different platforms through that organizational boundary, which we call our organizational boundary resource. We make a distinction. The boundary resources provided by each vendor, we call vendor boundary resources. That's a part of the product. And organizational boundary resource, because this is a boundary resource controlled by the regional health authority in this case. And these issues of security and resourcing are also, or functions or processes, are important here as well. That means it's this boundary resource that gives app developers, other systems, access to resources. And also the securing that, if you take Apple iPhone, it's Apple that decides which resources you get access to within the iPhone platform. But that model would not work within a hospital setting. It's a hospital organization that need to control which other application should get access to which data and which users should get access. So it's, and this boundary resource is then controlled by the hospital organization. And the hospital organization decide which resources should be made available, and they also need to have the control over issues related to security and so on. So this is, we call this a multi-platform infrastructure. Here is a little bit more detail, and it's a multi-level, multi-platform infrastructure, because the aim with this program was that everything should be transferred to the regional level, that they should share regional databases. That means, in this context, regional platforms, while the national authorities want everything to be national, and that would be a national platform. And there are some national platforms. The nurse working solution, the e-prescription solution, the summary care record, the national quality registers, and so on. That's available national platforms. So I move to the last illustration. So this will be then an infrastructure with platforms on 3 different levels. You have the hospital platforms at the hospital level. You have platforms on the regional level, and platform on the national level, and each of them have their boundary resources which are controlling the access to the platform. So this is a model which we believe that they have taken some steps towards, and it's a model which they could continue to work towards. This consolidation strategy of this program was that, I didn't say it explicitly, but it was sort of the idea that everything should be transferred to the regional level, and it should be done in a more or less big bang process. Tendering process, buying one product, then implemented certainly one hospital one by one, but within a short time at all hospitals. So this is a model that approves that and supports that you will have resources at different levels, but also support a gradual evolutionary process where you can transfer functionality data resources from one level to the next step by step. Final slide, final comment. In some of the research literature, it said that managing these large-scale solution portfolios, it's about managing tensions. And we are saying that the main tension is set between stability and change. And in a way, you need both. And stability is related to integration. When you integrate, something becomes hard to change, and it becomes stable, whether you want it or not. And that means also that if you want to integrate, it requires stability. And then also standards are hard to change. And centralized control is also related to stability. If you want to change, you should not integrate, but split, keep things apart, modularize, it's called within engineering. And that allows for variety, and also decentralized control. If you want change, innovation, you need decentralized control. So it's how to deal with this, and in many ways you need both, but then it's how to deal with the combination, find a balance. And this model, just one last sentence. Yeah, and this model is also support a way of managing tensions. That the more stable things are, the higher level you can put it, and you need, and as you stabilize and remove variety, you can transfer it towards a higher level. And the more, if you are doing innovation, something new, or if you are working within an area which is developing quite fast, it should be at a more local level. And you can move back and forth between this. So the more stable things are, you can put it here, and then you can have centralized control, and what is here you can integrate and so on. Okay, stop there.